Okay. Well, good morning, everyone. Thank you for, like I said, coming out. Thank you, Afi, for inviting me to come out here. My name is Josh Schiffman, and I'm a pediatric oncologist, so I'm at the receiving end of all of the work you do, and I have a slightly different perspective. And I'm going to share that with you today. Lucky you. Before I start, though, one of the things that really I've been thinking about, just this morning even, listening to all these great talks before me, is, it's interesting. You're finding all of this great stuff with your cytogenetics, with the microarrays now. We're going to talk about another platform. And then you're handing it off to us as the clinicians, and what are we doing with it? Well, the truth is really not much. So that Icaros, that's fantastic, but we're not yet incorporating that into clinical trials, and we've known about that for 4 or 5 years now. So I think one of the challenges for all of us in this room, and maybe we can talk about this during the discussion, because there will be plenty of time, is how do we work together to make these findings meaningful, to translate from the cytogenetics lab to actually changing patient care? Because we know you can identify these changes, but how do we actually make them meaningful? And so we're going to talk a little bit about that today. We're going to talk about biodiscovery and prognosis, and we're going to talk about paraffin samples. Now, here's the cancer challenge, and many of you know this already. You're dealing with cytogenetics and cancer, but cancer is the second leading cause of death worldwide. There are 8 million deaths per year from cancer. In fact, 15 people die from cancer every minute. So just think about it. That's a staggering number. Half of all men and a third of all women will get cancer. So usually what I like to say when I give these talks, and you think about that statistic, to put it in perspective, if we divided the room, right? I'm sorry to say that everyone on this side of the room is going to get cancer, but there's lots of empty seats on that side. So you guys can switch back and forth if you want. But cancer's out there, right? It's a problem. We need to do something about it. And particularly, for me as a pediatric oncologist, cancer is the leading cause of disease-related death in children. How many people know personally of a child with cancer? Raise your hand. Keep your hands up. How many people know of a child who's died of cancer? Right? Many of the hands are still in the air. One child that dies of cancer, in my opinion, is one child too many. And that's why we're here, and that's why we do what we do. Let's talk about paraffin. Now, I know all of you are cytogeneticists. Do we have any pathologists, any closet pathologists lurking in the room this morning? No pathologists. Okay, good. So we can talk freely about the pathologists. Okay, now I have to say this, and Sarah, who I work with back at Utah, knows this is true. Some of my best friends and literally neighbors are pathologists, including heme pathologists. Now, pathologists have a very distinctive clinical psychiatric disorder. And the best way to describe that is if you've ever seen the program on television called Hoarders, right? Where you can't throw anything away. That's what these pathologists are like. And they admit it, and they smile, and they know it's true. So a patient comes in, a sample comes out, God forbid you throw that sample away. Let's embed it in paraffin, save it in wax so we can have it forever. And they stack up. Have you ever been into your pathology friend's office? They stack up these paraffin blocks. They get so high until they basically literally spill over onto the floor. And they say, well, we can't throw them out now. We got to ship them to the warehouse. And if you've ever seen these warehouses, they're all throughout the country, all throughout the world. It's like that scene, I describe it in Raiders of the Lost Ark. If you've seen that last scene where they're putting the Ark back in the warehouse and it just stretches for miles and miles with wooden boxes. That's what these warehouses are like. But they're patient samples. And it turns out that these patient samples are really important. Why? Because they're linked to clinical data. Each one of those little blocks that our friends and pathologists are loath to throw away has clinical data associated with it. And that means that there are more than 1 billion of these paraffin blocks around the world. And these blocks, as it says here, are an incredible resource, but a huge challenge. But they've been extensively annotated, and they can really help us understand cancer. And of course, this was published in Nature, and if it's in Nature, it must be true, right? So clear, here's your proof right here. But all kidding aside, this is really so valuable when you're trying to make that prognostic link, when you're trying to find the meaning, the clinical meaning of these samples. Now, previously, this came out in 2007. Even back then, it was a challenge to work with these samples because, as you know, the formalization process, it degrades the DNA. And so it makes it really hard to do genome-wide studies. Fortunately, folks at AFI and other companies before AFI came up with a solution. And it's called molecular inversion probe. Now, how many people have heard of molecular inversion probes or OncoScan? Okay, so a little, maybe about half or so. Well, the thing that's nice about the probe, and this is how it works, and of course, I don't have to tell you guys, it's not really in color. This is just a depiction here. This is an oligonucleotide array. And the way it works is you have about 20 to 30 base pairs on either side that are homologous for the strand of DNA that you're interested in. It's got a little gap in the middle where you eventually fill in a SNP. I'll show you that in a second. Built into this probe itself are cleavage sites, so when the probe binds, you can actually break the probe down. But most important are these primer sites that can amplify the probe when it binds, and then this, the unique barcode sequence. This is a non-human barcode sequence. So unlike a lot of the other microarray technologies that are out there, you amplify your DNA, and your amplified DNA binds to your microarray chip. Well, that's okay, but if your DNA quality isn't that good to start with, if you're amplifying pretty much crappy DNA, you're going to get crappy DNA out, right? But here, it's a synthetic probe. So once the probe binds, it's not the DNA, regardless of the state of the DNA that's being amplified, it's the probe. And this barcode right here, this sequence, binds specifically onto the microarray chip. The startup is only 70 of DNA. You only need 75 nanograms. And the truth is, we've gotten it to work as low as 3 nanograms of DNA. Now, I'm not supposed to tell you guys that, but 3 nanograms is what we've had high-quality results with. This is from a review of the microarray technology that we wrote, the MIP technology, OncoScan as it's called, and it's in your packet. So I'll refer you to that for more detail. But this way that the assay works, and by the way, this is going to become available for all of your labs, like we said, in probably the Q4. Okay, so Q4. So that's what, December or so, or a little before December, maybe September, December. Okay. All right. So. You guys still with me? I know it's been a long 24 hours getting here. Quite a journey. Okay, so here's the way that works. So you've got all of your probes. This is multiplex. There are 300,000 probes, at least in version 2. They all go into the tube at the same time, and they bind to where they need to because the probes match up. There's a little gap there. You fill in the gap. If it is filled in, you circularize the probe. You basically chew up everything that's not bound, including those probes that don't bind. That's how you find their deletions. You cleave those probes, and you amplify them, and you bind them to an array. And that gives you really highly sensitive and specific results on your paraffin samples. And that's what we're going to talk about. What are some of the advantages? Well, you can choose any of these non-repetitive sequences of interest, so they've gone across all of the genome, so you've got good backbone coverage, but you also have enrichment for your cancer genes, reduced DNA requirement, works in paraffin. You have a pretty dynamic copy range. I'm going to show you some examples where you can get numbers up to 60 reliably, and it's very sensitive and specific, so it works quite well. All right. Now the fun part, right? The data, while you're all in the seats and still awake, hopefully. Okay, so this is where Sarah and I come from, that little star right there in Salt Lake City. Now in Salt Lake City, at our children's hospital, we see actually the entire Intermountain West region. We're really one of the only major children's hospitals in this whole area, so we get a lot of referrals. But even so, that only translates to about 170 new pediatric cancers per year, so about 30 to 40 ALLs, 6 to 10 Ewings, 3 to 5 Burkitt's lymphoma. If I want to do a study on Burkitt's lymphoma, if the airport's open and I can get home later today, and I want to start this afternoon doing a study on Burkitt's lymphoma, if I want to get 30 samples, it's going to take me 10 years if I do that prospectively. But if I use paraffin, I could probably collect all of those samples in maybe 2 to 3 weeks and get the assay going, which takes about 3 days. So you can see using paraffin is a really good thing. It really can speed up your work. ALL, you've heard about it. Clinically, what I'll tell you, again, as the putting on my practice and clinician cap, is this is the 3rd most common diagnosis we see. And we have pretty good cure rates now. It's about 80 to 90% because we risk stratify therapy based on all the work that you do, based on the information you tell us about the cytogenetics. But that 10%, that relapse or that recur often go on to die. So we need to do a better job picking those people out at front, because remember, one child who dies from cancer, one child too many. So one of the things we did is we got 60 samples, and these are paraffin. So you guys obviously work with the live cells, and that's fantastic, and that's exciting. And as an aside, I have no clue how you can read those spreads. Those all look like fluff to me, and it is so damn impressive every time I see that. And Sarah, you can stand up here and you can say, oh, you see that little cloud? That's clearly a translocation. That's all schmutz to me. So you guys keep it up, because that is fantastic. But fortunately, microarrays, you know, that can really help too. So that's why I do microarrays, so I can understand it. So, getting back to our friends, the hematopathologists, the cytogeneticists, you deal with the live cells, but what happens when they get the actual clot, they get the sample, we do the bone marrow aspirate. Anyone ever seen a bone marrow aspirate being done before, by the way? A handful of you? All right, so we take a very big needle. Fortunately, the kids are anesthetized, sleeping, relaxed, and we put the needle in, we pull out the aspirate, which is sort of like blood, it's got the leukemia cells, and they make the smears, and we give some to you guys, and you grow them, and you make your pellets, and you do your spreads, and hopefully now microarrays. But the pathologists, our dear, dear friends, the hoarding pathologists, they say, well, here's a piece of blood here. I'll just put it on my counter because I can't throw it away because I'm a hoarder. And they put it on, and it clots. And they say, oh, look, there's a clotted piece of blood on my desk. Well, I can't throw that away. I better put it in wax because maybe someday I'll need it, right? I mean, really, it's a pathology. That's why they call it pathologists. So, I just made that up. I'm going to use that in the future. Anyway, so the pathologists, they take that aspirate clot, and now we have 30, 40 years of these wax blocks of clots filled with leukemia cells. So we were able to go back. We got 60 of these over the past 10 years, and we take out the paraffin blocks, we shave off ribbons, we extract the DNA, and this is the results we get. So this is the Nexus browser, which you've heard a little bit about from biodiscovery. And here, these are the old colors, so my apologies, Sarah. I know they're supposed to be blue and red now, but is anyone colorblind in the room? You're not going to admit it anyways, but that's okay. So you know this has changed from green to red to blue to red. But so the green, here's the amplifications, and these are all the 60 samples. We run them individually. This is all the data pooled at once, just to give you a snapshot. Here's the chromosomes, much easier to look at than those spreads that you guys do, I think, but this is electronic. And so you see the green here, so trisomy 4, a lot of samples with trisomy 4 and trisomy 10, 14, the common ones that you see all the time, trisomy 21 as well. Here's just another representation of it without the actual nice chromosomes in the bands, but you can see gains 4, 6, 10, and so on. And then there are a couple of deleted regions here, focal deletions. And well, here's, again, just to blow up and show you, here is just a colorful representation of it. Now, the thing to point out is here you can see hemizygous deletions, you can see homozygous deletions. This is very clear, all right? There's no missing these. And, of course, with the Nexus software or CHAS, you can make these calls, and these can be spit out for you. But just visually inspecting it, you can see that there are deletions. Now, what I want to point out is this is paraffin. Right? These are wax blocks. This is degraded DNA, and you're getting really smooth results. Here's another nice example of one. We'll blow it up. Here's obviously a trisomy 21. But look, even in here, you can see clearly a hemizygous deletion, and this has probably got some of those clones, mosaicisms, like we were talking about earlier, because this is copy number 1.5. And then here you go, a homozygous deletion within the hemizygous deletion. So this is very, very clear, high resolution off of paraffin blocks. Here's another example. These are relapse trios. Anyone, you guys have heard of relapse trios before? So this is becoming very popular now. People have spent their whole career trying to collect these very rare samples. The patient comes in, you have your diagnosis, they go into remission, so you have your normal, and then the third part, the trio, is the relapse. Clinically, what I can tell you is that when a patient relapses, we're not really thinking about collecting samples and doing research anymore. We're worried about the patient and how are we going to try to cure them. So that means it's very rare to get these relapse samples saved. But now, our friends, the pathologists who are saving everything in paraffin, we can go back to the paraffin so we can see what's in remission, what's in diagnosis, and here we can say on relapse, we have some new deletions that have arisen. And so if you can get enough of these samples, you can start to see what are the patterns, what's driving relapse. Here's again our 60 samples. One thing we noticed, just to point out something interesting, is there was a very focal deletion in a region called VPRB1. When we looked at Burkitt's lymphoma, which was mature B cells, compared to our precursor B cell, our immature B cell, what we found was this VPB1 deletion was very focal. It wasn't part of lambda light chain deletion, which is another story I can talk about another time. But suffice it to say, this VPB1 deletion, a focal isolated deletion. Why is that important? Well, VPB1 is actually a gene. It's part of the lambda, it's in the lambda light chain region, but what it actually does is VPB1 is the surrogate light chain. And so as the B cell is going through rearrangement and developing, this VPB1 gene actually goes with lambda 5 onto the surface and literally holds its spot. Why is this important? Well, B cells can't develop without that signal. The way I like to think of it, these young B cells, they're maturing, right? If they want to grow up and become functioning members of B cell society, if they want to have their B cell bar mitzvah, right? Or now that I'm in Utah, if they want to go on their B cell mission, right? They need to go through this signaling phase. But if VPB1 is not there, how can they do that, right? And they get locked in an immature state, and bam, we have a clue to leukemiogenesis. Is this associated with prognosis? Well, we're still trying to figure that out. But these microarray studies are ways that we can really hone in on these and try to understand it. And just to show you and convince you, here's a related region, and we've done PCR, and we can show that the data is very accurate. Again, paraffin. This is paraffin samples, but we can very clearly see diploid, hemizygous, homozygous, and it matches our PCR, which is one of the gold standards to actually assess copy number. So this microarray technology, it works. Okay, enough of leukemia. I'm sick of leukemia. We talked about leukemia all morning. Let's switch gears. Let's talk about solid tumors. Does anyone here do cytogenetics for solid tumors? Okay, good. You all do. Fantastic. Anyone do cytogenetics for Ewing sarcoma? Yeah, you all do. All right, great. Well, here's the thing about Ewing sarcoma. Ewing's is a real, oh boy, I could spend all afternoon talking about this, but don't worry, I won't. Ewing sarcoma, really fascinating disease, really deadly. When patients come in with Ewing sarcoma and they see me in our clinic, if we diagnose them and they have a spot on their rib and it's only one isolated spot, we have about a 60 or 70% survival. It's very intensive. They get admitted to the hospital every 2 weeks for many months. But we can usually cure 60 to 70%. If, however, that patient, and these are usually adolescents in the prime of their youth, usually athletes, high school, just enjoying life as they should. If they come in and they're sitting across from me in their clinic and they have a spot on their rib and say their pelvis, so they have metastatic disease, their long-term chance of survival, 5-year overall survival, usually 3-year overall survival, less than 10%. Okay, less than 10%. That is a death sentence. It is very difficult to be sitting in a room and knowing that teenager across from you is going to be dead in a couple of years. This has traditionally been a really hard disease to understand because it's so rare. There are only 400 to 500 new cases per year total in all of North America. So how can we study it? Well, we come back to our friends, the pathologists, who've been saving samples. And so now we're able to go back to the paraffin blocks and start collecting enough samples to say something meaningful. So we did a small study, which we recently published. We were able to get 40 primary tumors and 12 metastatic lesions. Now, the metastatic lesions, that's very interesting because usually clinically, the surgeons and the clinicians, we don't biopsy metastatic lesions because we know they're metastatic and we don't want to put the patient through the actual rigmarole of surgery, right? They got a spot in their lung and a spot on their rib, or a spot, sorry, lung and the pelvis, and we know what the pelvis is. We don't have to do a biopsy of the lung. We know what the lung is. There are a few cases, maybe once or twice a year at every institution, where you're not sure, maybe it's an infection, and so you do the biopsy. Previously, that wasn't enough to say anything meaningful, but now that we have actually paraffin, we can go back and we can collect over 10, 20 years enough samples to say something meaningful about metastasis and understand the genomics, right? So this looks like maybe a small number, but actually for Ewing sarcoma, this was a large number of samples. And most importantly, we had clinical data because it's all tied to paraffin. And I'll tell you, at each of your institutions, as at mine, there are med students and fellows who are very willing and eager to go through the medical chart and get this information for you if you want to do these types of studies. But most importantly, we had clinical outcome. here's just an example. Now, much different than the leukemia, when you do actually these microarrays and you look genome-wide. There are certainly some copy numbers, but they're not quite as common. Few are isolated. You have a couple of homozygous deletions here, whole chromosomes or half chromosome arms, but a lot more quiet than leukemia tends to be. Here's a summary slide, and here's our 40 samples put together. Again, green here is amplification, red is deletion. And we found what was in the literature, and that wasn't necessarily so surprising, but that was nice to see. One of the things, though, and this really surprised us, there was a focal deletion. So right here, here's what we're looking at. Here's the copy number. So we had a copy number of 1. Here's 0, that's diploid. Here's a copy number of 1, and right in the middle of that 1, this dropped off. And that was a homozygous deletion, and that was in a gene called INI1, or as you may know it, SMARCB1. Right? Who's heard of SMARCB1? Yeah, okay. Who's heard of INI1? Who's still awake? Just checking. Okay, so this is a gene that's known to be deleted in a tumor called rhabdoid sarcoma, or ATRT. And that's how you make the diagnosis, pretty much. You have a small round blue cell, you're suspicious on histology, you see that this is deleted, you do FISH for it and it's absent, you say, okay, or you stain for it actually, and you say, okay, well this must be a rhabdoid tumor. But these weren't rhabdoid tumors, these were Ewing sarcoma. And we found another one. Now I have to say, in this kind of, people who do microarrays will hopefully be able to relate.
Well,
yeah.
So these are, you keep saying, these are Ewing sarcoma based on what?
We'll get there.
Because
yeah.
I have done 10 cases of sarcoma by microwave. After the fact, I found the rearrangement.
Yeah.
And they were always normal, but it wasn't at that high resolution anyway. But when you said, oh, these were found in rhabdoid, and now these are Ewing sarcoma, so confirmed by?
Confirmed by, hold that thought. 2 slides. We'll get there in 2 slides. A great question. And maybe you reviewed the paper, because that was the question we got to. But we'll get there. Okay. So I'm not blowing you off. I will get there. Okay. And that's a very important question. I'm glad someone asked it. So here, I was about to say, though, people who look at microarray, I find this stuff so beautiful. I could just look at this all day. I could put this up and frame it and put it on my wall. My wife would probably leave me, but kids would think I'm crazy. They already do. But I just think that's just so wonderful. I mean, and look, right? I mean, you could see it so clearly. Here, diploid, hemizygous, homozygous, hemizygous, diploid. It's so clear. It's so intuitive. I just love this stuff. We also found, and I'm glad we were talking about LOH, or absence of heterozygosity. Here's a sample where it was complete absence of heterozygosity. In this case, I would call it loss of heterozygosity of this focal region with INI1, with SMARCB1. And it's otherwise, the copy number is diploid. So I got really excited, and I said, this is fantastic. What a new discovery. Ewing sarcoma, we'll come back to it. What we think is Ewing sarcoma. It's missing INI1. Wow, this is fantastic. We got to publish this. So one of the mentors that I have, who's a little more senior than I am, and has been around longer than I, said, well, not so fast, Josh. Before you actually publish this, you want to show that it just means something. This is just microarray stuff. No one believes microarray. You've got to actually show that it's important. So here is our sample. He said, why don't you stain it to show that it actually makes a difference? So we stained the germline, because remember, the bone marrow aspirates, they're saved, so we have the normal. And here you see the INI1, SMARCB1 staining. It's brown, just like it should be. And then we stain the tumor. It's completely absent. This tumor was a translocation 1122, EWS fly. So we said, okay, well, that's pretty good. And I said, this is fantastic. And we did all 3 of those samples I showed you. Here's just a representation of the others that didn't have a deletion or LOH. And you can see very clearly, these don't stain, these do stain. Here's a nice internal control with some of the vessels that do stain. So I said, great, now we can publish. And this colleague of mine said, well, not so fast, Judge. Utah, it's kind of a funny place, politics aside. People don't necessarily believe everything that you show. If it's just from Utah, you've got to get another data set. So we were actually able to get a data set from COG, and these were all patients that had been clinically diagnosed, enrolled on their COG trials, put in the biology bank, and this tissue microarray showed about 10%. We also got some from Michigan and showed about the same thing, 7 to 10%. So it looked like 7 to 10% were missing this, and we said, okay, now we can study, and we submitted it, and the reviewers said, just like the question, how do you know this is actually Ewing sarcoma? Maybe these were just misdiagnosed rhabdoids, and that's great that microarrays can help you find that you made the wrong diagnosis. So, well, let's look a little further. So we are actually able to get in touch with someone, Andrew Rosenberg. I don't know if any of you know Andrew, but he is a bone tumor pathologist expert. He wrote a textbook. I think it's called like Bone Sarcomas. That's all he called it. It's a big textbook. So he knows. He's the expert. So we sent him all of the samples, blinded, and we said, look, review these and tell us what you think. And he said 3 of them looked to be, or 4 of them actually looked to be conventional Ewing sarcoma. They were CD2, most of them, well, half of them were CD99 positive. 1 it wasn't done, 1 was negative, but they all appeared conventional. We did have FISH for some of them that were positive, but others were a bit atypical. They didn't look quite like Ewing's under the microscope. He said, well, you know, there could be, they're not rhabdoid tumors, but they have rhabdoid-like cells, but they have these atypical Ewing cell, and so that basically led us to conclude that, you know what, maybe we stumbled, using microarrays, we stumbled upon a new type of sarcoma, a hybrid. It's not Ewing's, it's not rhabdoid, it's Ewing's rhabdoid. It's this myxoid sarcoma. And so now we're expanding this, and the reviewers were satisfied because we backed off and we said, well, maybe it's not actually classical Ewing's, but it's a new type of Ewing's, because it's certainly not rhabdoid, and it's not classic Ewing's either. So we're now pursuing this and trying to see how we do, and try to understand the clinical outcomes associated with this. Just moving along with the Ewing story, so we found an amplification here in another sample. It was copy number of 11, which is quite high. And a gene in there called CEBPB, which we were interested in because it's involved in collagen formation, and these bone tumors involve soft tissue and bone, so collagen is right there in the mix of it. We stained it to show that it was actually important. Those samples that had, this one that had 11 copies, this looks like my 3-year-old took a Sharpie, a brown Sharpie, instead of writing on the wall like she likes to do. What a pain. She instead wrote right in this slide, right, colored in the nucleus. Here are the ones with 3 copies, a little darker staining. The one with 2 copies, more light and more diffuse. So at least biologically, functionally, if there's an amplification, it's translating into more protein. When you look at the curves, you can see a difference. Not a lot of samples, but for overall survival, if you have this gain in that region, look, you all end up dead. I would never want to have Ewing sarcoma, but if I do, I don't want to have that gain. The other thing we were able to do was look through our sample set and find all of these regions that had some association with outcomes. Some were quite strong to the -7th, some were a little bit weaker, 0.04. So we said, let's think about this like our friends, the cytogeneticists and the pathologists. The patient comes in on day 1 in the clinic, regardless of whether they're metastatic or not. We analyze their tumor on OncoScan, which now we'll be able to do in 2.5 days, turnaround time. And we can generate a report, and we would be able to say, do they have any of these particular gains or losses? And we can put them in 2 categories. They could have none, right, multi-factor copy number negative, or they could have multi-factor copy number positive, meaning they just have at least 1, maybe 2, maybe 3, maybe all 8. So it's none versus at least 1 of these 8. How do they do? And this is how they did. So they had about an 80% event-free survival, meaning without relapse, and about 40% relapse if they had any of those gains. But what we really care about is overall survival. Because you can relapse, but what I want to know is once you relapse and I treat you, how do you do? And look at this. You don't often see curves like this in the field of oncology. Here's 100% overall 12-year survival. If I went back to Salt Lake this afternoon and want to do this same study, it would take me 12 years to do it prospectively. But because I could use paraffin, this was done in about 9 months, and 8 of those 9 months was getting the clinical data. So this is huge. One thing that I should point out as I walk over here is the curve. So I can fit my whole hand in this curve between those patients that lived and the patients that died. Why is that important? It's not just because it's projected big. That's a big difference. 100% survival versus 40% survival. Why does that matter? Well, in the world of medical oncology, when you're looking at survival curves, you can almost only fit your pinky between those curves. I get these throwaway oncology journals. It's like a game between my wife and I. She tries to throw them away faster than they can stack up, and I try to read them. They usually all end up in the garbage. All of those glossy throwaway journals, they all have advertisements. They look like this. I don't know, do you guys get journals like this? I get tons of these, all right? Now look at this. This is millions, if not billions of dollars on marketing for prognosis and outcome. And what's it tell you? Well, there's a difference in 1-year survival, 51 versus 44%. 2-year, it drops to 23 versus 15. And you can't really talk about anything past that. The patients all end up dead. You can't fit your pinky between those. And the overall survival, 12.3 months versus 10.3 months. That's only a 2-month difference. But it gets a big glossy ad and billions of dollars and a fancy name. Here's another one. This is new. This just came out last year. This is my new favorite one. This is for renal cell carcinoma. A couple of things important to point out about this ad, if you haven't seen it before, is look, 6.7 months it says. But you know, it's really 6.7 versus 4.7. So it's not that you live 6.7 months longer, it's just that's 6.7, that's 4.7. It's just 2 months longer in the middle of these curves, everyone still dies. The other thing to point out is I don't know what the hell this guy was thinking to put a tattoo on his arm, right? Two things. Clearly he didn't have the same Jewish mother I had growing up, because that would not be allowed. And even if I did it anyways, I would certainly never live it down, because this should say 2 months. It shouldn't say 6.7 months, right? So these people need to go back to their Cialis commercial in their bathtub and think about their life, right? Because seriously though, I mean, this is not really a big difference in outcome, and we're talking about childhood cancer. We want to find things like this. Now, I admit this is a prognostic marker, this is not a therapeutic, but still, this is what we should be striving for. Just finishing up here, one of the things, metastatic, I told you is very important. Now we can actually take the metastatic samples, and we can analyze them. So here's the primary tumor, and what we imagine happens is there's a mutation in a subclone. This subclone daughter cell goes on, and it acquires the ability to spread. Well, now we can actually measure this by microarray. Here's the primary tumor. Here is our paraffin block from the metastatic tumor, and you can see it's gained a region here in 6. Here's another example. This one has some more deletions and amplifications. We've looked at the primary tumor. We look at the metastatic tumor. Very interestingly, this has acquired 2 new deletions that weren't in the primary tumor in 10 and 13. What's also interesting for those of you who are microarray aficionados is that this represents a subclone, because not every cell in this tumor actually has this deletion, but you know it's not a problem with normal contamination because you do have whole copy number loss of 1 there. So you learn a lot about metastatic tumors by doing these. And you can imagine if we all team up together, if each of us has 10 or 20 of these stored away at our own institutions, we can look at hundreds of them and maybe figure out what's driving metastasis. Burkitt's lymphoma, I'm not going to spend too much time on this, but it's the same type of story. We can get genomic DNA. We looked at 32 paraffin samples as old as 10 or 12 years. We looked at the bone marrow aspirate clots for normal comparison, and we were able to find some recurrent regions in 1Q, loss of 17P, where P53 is located, and gain of 13Q. We were able to show the gain of 13Q was very specific, and you can zoom in and find your recurring regions, and they were microRNAs in that region. We were able to look at the expression of microRNA and actually show that the expression correlated with the gain. Those samples that had the gain had higher expression. We were actually able to look then at that region and show those samples, those patients that relapsed, were more likely to have a gain in that region. So 2 of 3 with the 13Q31 relapsed versus 1 of 21 without the gain. So it's actually, this has now been published, but this is a small number, so now we are working again with colleagues to basically validate this and show maybe this is a prognostic signature that we can start thinking about to risk stratify. Burkitt's has a 95% cure rate. Those 5 to 10% that relapse all die. If you knew on day 1 of therapy, or day 2.5 after you run your microarray, that they have this gain, you would give them a different therapy. And maybe you could save their lives. Here's just some fun-filled examples. This is rhabdomyosarcoma. This actually presented initially as a leukemia. We thought this was a leukemia. They were small round blue cells in the circulation. We did the bone marrow. We later diagnosed rhabdomyosarcoma. Look at this gain. Pretty obvious here. Working with colleagues at ARUP, this is the microarray data. We were able to actually go ahead and get FISH data and show that there were some double minutes here and that there were amplifications of NMYC and MuSK, and they were translocated into this double minute. Right? This patient unfortunately went on to die as well. If we can get enough of these rare bone marrow involved rhabdomyosarcomas and run microarrays, maybe we'll find something in common and we can switch therapy early on. Lymphoblastic lymphoma. So I don't know if people know Sherry Perkins. She's a hematopathologist. She's at ARUP. A couple of you are nodding your head. A few of you are denying it. In any event, Sherry had slides. She does lymphoblastic lymphoma. She heard me give this talk, and she said, you know, Josh, I've had these slides from one of the COG trials sitting in my file cabinet for about 8 or 10 years. I wonder, could you do microarray on them? Can you do this MIP stuff you've been talking about? Sure, let's try it out. We'll put them on between the Ewing samples and the leukemia samples. So she pulled out these slides that had been sitting in the dark, minding their own business, literally getting dust on them. They were paraffin, so they were preserved. We took them, we scraped off the paraffin, we extracted the DNA. Remember, 8 to 10 years sitting in the dark, minding their business. We pull them out, and this is the data that we got. This is very clean data. This data is cleaner than some of the fresh microarray data that you've seen on blood that was just drawn, an hour earlier. This is a really good assay because of the way that it's designed. So samples 10 years old, you're able to see high resolution data. And just zooming in case you didn't believe me, so here's a homozygous deletion in one of the actual T-cell receptors, so not surprising that it's deleted, but look how clear it is. You can't miss that. That is very clear, very high resolution. Here's another one, again, just to show you how strange I am. I could look at this all day long. This is just, Sarah, don't you think this is beautiful? I mean, she loves this stuff too. So if you need to find us, we'll be in our offices in Utah just looking at these pictures on the screen. So diploid, homozygous, hemizygous, there's the T-cell receptor, and then it goes back up to diploid. But remember, this is slides sitting 10 years in the dark in the file cabinet. So you probably all have cases back where you work where you can pull out the interesting ones that you saved too, because we're all a little bit of hoarders inside if we think about it, and say, oh, maybe one day I'll need this for something, or maybe you have the pellets saved in the freezer. So here, this is what you can do, and you can find out interesting things. Now, we did have some samples that failed, but what I want to point out is even the failed samples, you can use that allele ratio data to actually identify with confidence samples that have failed, but still get information about them. That's important. So we've done GBMs, melanomas, brain tumors, GIST, ovarian tumors. Anything in paraffin is fair game. And I have a couple minutes, so the very last story I'll tell you is not quite cancer related, but more hematology related, but really I think drives home the point of how useful paraffin can be. So the Braddock-Carey syndrome, has anyone besides Sarah ever heard of Braddock-Carey syndrome? No. Oh yeah, someone who's heard me give this talk before. So John Carey is this medical geneticist. The way I describe him, I don't know if Sarah can agree or disagree, I think he looks a little bit in my mind like Darwin must have looked, Charles Darwin. He's kind of short, he's bald, big bushy beard, big bushy eyebrows, just world-class geneticist, editor of the American Journal of Medical Genetics. He's got more Carey syndromes named after him than he knows what to do with. The med students hate being on rounds with him because they never know which Carey syndrome is going to pop up. Well, almost 20 years ago now, he described with Steve Braddock, who was a genetics fellow at the time, 2 kids who had come into Utah. And they said, oh, these 2 kids, they've got some unique malformations. They have low platelet counts. They have a problem with the formation of their jaw. Their corpus callosum, the part that separates the brain, it's missing. They have distinct faces, and they both have developmental delay. Well, this is very interesting. And so they described it, and because it was 20 years ago, they said, okay, we're now going to call this Braddock-Carey syndrome. All right. Well, microarrays have come online since then, and a lot of people started publishing microdeletion syndromes. And there were several reports that said, this 21q22.11 to 12 microdeletion syndrome it has an overlap with this Braddock-Carey Syndrome because it's got some of the same features. And so actually someone wrote a letter to the American Journal of Medical Genetics, and they said, "Dear Dr. Carey," because he's the editor, right? "Dear Dr. Carey, don't you think that these microdeletion syndromes sound an awful lot like your original Braddock-Carey syndrome?" Well, Dr. Carey wrote back, because he's the editor, and you can do that, and he said, "Dear reader, yes, this is a very astute observation, and it's probably true, but alas, we'll never know. This was 20 years ago. One of the patients died. The other one moved away. Thanks for your comments, and keep reading our journal." All right? Well, Sarah actually heard me giving this talk somewhere around Utah at the university, and she said, "Hey, Josh, what do you think if we could get some sample, some paraffin sample from the original Braddock-Carey syndrome and run this OncoScan on it? Some old paraffin sample." Okay, I said, "Great. We'll put it right next to the leukemia, now the lymphoblastic lymphoma, and the Ewing sarcoma, and we'll see what we find." So, working with the pathologist, she was able to get a specimen, a piece of liver, which they had done a complete autopsy at the time, and they were unable to find anything abnormal. So a piece of liver, 20 years old, 2 decades old, right? Sitting in paraffin, pulled it out, and this is what we saw, right? This is very, very clear. Homozygous, hemizygous, homozygous. You don't even need that PowerPoint magic to see that that's there. I said, "Wow, this is cool." And then Sarah did a lot of detective work that she can tell you about during lunchtime. She was able to track down the original other patient. This patient had died. This was the paraffin autopsy. And she was able to run, I don't know if this was cytoscan or SNP6 or, yeah, this looks like cytoscan, on the blood from the other patient who was still alive. And what I'll point out is the 20-year-old paraffin looks a little bit cleaner to me, but that's, I'm just saying. But anyways, when you compared the region, there was an overlap. And so here it was. They were right, 21q22.11. So 20 years after the fact, we were able to go back to the original paraffin block and define the actual genomic deletion that causes Braddock-Carey syndrome. How cool is that? So I'll leave you by saying copy number changes correlate with clinical outcome in childhood ALL, Ewing sarcoma, Burkitt lymphoma, and many others. This is going to lead to novel targets for developmental therapeutics, but success depends on clinical collaborations, and I include all of you in the clinical collaborations. We need to have better discussions and back and forth and sharing of data and clinical information to really figure out how do we make these discoveries meaningful, how do we move them into the clinic. So paraffin is no longer a barrier, and I look forward to talking and working with all of you as we move the field forward. Of course, all of this is due to many, many people working in the lab, the patients, the families, Sarah, others, the research support. And the final slide, this was actually taken a few months ago, not outside of the hotel, which I suppose it could have been. This was actually in Salt Lake City, and that is my son, and I would point out he is not wearing a hat, gloves, or coat. But that is a story for another time. Thank you very much for your attention.